Ladies and gentlemen, it's with great honor that I introduce our first panel. It's entitled Radical Surgery Required, Rethinking California's Healthcare Workforce. Our panel will be moderated by Richard Figueroa, Executive Director of the California Endowment, and our panelists include Jeff Oxendine, Co-Director of the California Future Health Workforce Commission, Pilar de la Cruz Simulian, MSN-RN with the California Board of Nursing, Toby Ewing, Executive Director of the Mental Health Services Oversight and Accountability Commission, and Eric Brown, President of California Telehealth Network. Let's give panel one a warm welcome.
As was mentioned, I'm Richard Figueroa. Whoops, I didn't think, did I do that? Okay. Whoa, go back. I'm going to put this away. I'm a director of the California Endowment. The endowment is the largest healthcare philanthropy in the state, and we work in Sacramento and statewide working on healthcare coverage issues, healthcare workforce issues, and the larger issues around the social determinants of health, i.e. The kind of air we breathe, where we drive, what kind of food we have available to us, what kind of exercise opportunities we have available, all those things that kind of impact health. Prior to this position, I worked for 30 years in government. I've worked for several governors, including with Mr. Gore here before. Although I've been through 5 transitions, gubernatorial transitions, never been through the one that we're about to see, because there hasn't been a Democrat-to-Democrat gubernatorial transition since 1886. And people think, gee, as blue a state as you are, and all this kind of stuff, but we haven't had a Democrat-to-Democrat transition since 1886. So there's no one alive that has experienced what we're going to experience. Interesting enough, in 1886, the elected governor at that time was the mayor of San Francisco. That came up to take over with another one from a previous Democratic governor. So anyway, I'm very, very happy to be here. I always make the right turn off of I-5 to the fast food. I've never made the left turn, so that was something different for me today. So what I want to do is I want to introduce the panel that's here. And then I'm going to talk a little bit about kind of how we got here and what this particular panel is about. And as was mentioned before, this will be the kind of the unveiling of the first time that any public venue, at least, has been discussing the 31 recommendations of the Workforce Commission. So this is an August time, at least for one of the principal writers and investigators here. So to my left is Mr. Jeff Oxendine. Sorry, some of these have pretty significant CVs here, so it'll take me a couple minutes. He's the president and co-founder of Health Career Connections. He's been a health executive, educator, and consultant for 27 years. He's held senior administrative positions in hospitals, medical groups, academic institutions, and his own consulting firm. He's currently the Associate Dean of Public Health Practice at UC Berkeley School of Public Health. He's also a leader in California Health Workforce and Diversity efforts as co-director of the California Health Professions Consortium and the California Health Workforce Alliance. He's also the co-director of the California Future Health Workforce Commission, which we're going to talk about in a minute. He teaches healthcare management at UC Berkeley School of Public Health, and previously taught for 5 years at the Harvard School of Health, Public Health. He obtained his master's degree in business administration and public health from UC Berkeley, where he met his other HCC founders. Directly to his left, in space, not necessarily politically, is Pilar de la Cruz Simulian? Simulian. I was going to check on ahead of time. MSN-RN. She's been a registered nurse for 50 years. And this is, you're going to find this CV very interesting. I've never read one like this before. She graduated from O'Connor School of Nursing in San Jose in 1968 and also attended Santa Clara University. She served as a manager of the critical care units and emergency departments, as well as the vice president of education at Fresno Community Hospital, where she co-developed the Paradigm Nursing Program in collaboration with Fresno City College and 4 other local hospitals. This contract education program helped produce over 750 much-needed additional registered nurses for the Central Valley. In 2003, she became the chief nursing officer of the Fresno Heart Hospital, helping to open the hospital to serve cardiac patients. In 2006, she retired, note the word retired, from, number one, from community hospitals and was invited to take a nursing faculty position at San Joaquin Valley College. In 2007, she began her work with the Hospital Council of Northern and Central California and later worked as the diversity director for the California Institute for Nursing and Healthcare to recruit more minority students into the nursing profession across the state. In 2011, she was recruited to Chula Vista to serve as the nursing director of the United States University. She retired again in 2013 and returned to the Valley, where she was invited to join the faculty at Fresno State University as the director of the Central California Center for Excellence in Nursing, where she successfully brought in over $2 million in grant monies for a nursing program. Her third retirement came in 2017 when she left Fresno State and was hired by the Diocese of Fresno through a grant from Catholic Extension to work on outreach for rural areas, focusing on educating the Hispanic population on health care. In addition to her work, and I think it was mentioned earlier, she was appointed by the current governor to serve on the California Board of Registered Nursing, which oversees the practice of 435,000 registered nurses in California. I don't know if I could ever retire and unretire that many times. Directly to her left is Toby Ewing. Dr. Ewing is the executive director of the Mental Health Services Oversight and Accountability Commission, the state agency that oversees mental health services in California. Dr. Ewing has worked on governance reform, government oversight, and improving outcomes of public programs for many years. He's worked on a range of public policy issues, including mental health, child welfare, immigrant integration, workforce and education, and veterans projects. From 2011 through 2014, Mr. Ewing served as a consultant to the California State Senate Governance and Finance Committee. He also served as director of the California Research Bureau from 2009 to 2011, and he was a project manager with the Little Hoover Commission, which is an independent body charged with improving government. He did his undergraduate studies at Grinnell and has a PhD in sociology from Syracuse. He also served as a Fulbright Scholar in Central America. Directly to his left is Mr. Eric Brown. Eric Brown is the president of the California Telehealth Network, which is one of the largest consortia of safety net clinics and hospitals in the nation that participate in the Federal Communications Commission Rural Health Care Program Broadband Subsidy Program. As a nonprofit California corporation, CTN provides broadband and virtual care technology services to over 300 clinics and hospitals in rural and medically underserved communities. CTN also operates the California Telehealth Resource Center, which provides federally funded technical and programmatic assistance to California healthcare providers interested in telehealth adoption or expansion. Mr. Brown was appointed president of the California Telehealth Network, or CTN, in 2010, after a distinguished career building and running broadband telecommunication systems in urban and rural communities around the country. Phew. So quite an august panel that we have for you today. So if I can just kind of go to my overview real quick, which is the next slide here. Should I just say next slide or push a button, or? Now I can use the clicker. Okay, which direction? We'll see. Okay, so anyway, so I work for the California Endowment, and as part of our work, we have funded local health pathways programs, as well as statewide health activities through the Office of Statewide Health Planning and Development and the Health Professions Education Foundation. So in looking ahead to the next state administration, which is now, of course I wrote this a couple weeks ago, at least one candidate appeared very interested in health policy, and that's one that looks like is the governor-elect. And the other one was very interested in health workforce as kind of a jobs and economic development strategy. So TCE, as my foundation is known, and other health foundations were concerned about the lack of a health workforce master plan in California, or a strategy that could accompany any other large-scale changes in the healthcare coverage or healthcare delivery structure. So we got together, let's see. There we go. So 5 of us got together, and these are the 5 foundations listed here, to put our heads together and collectively fund a commission composed of public and private membership called the California Future Health Workforce Commission. And one of the very first products of that effort you had on your table, which is the big, thick report on kind of where we are, what we've learned in the past. And from that, the commission has now been meeting and has a set of recommendations that Jeff is going to be talking about in a minute. And then we'll be asking the others on this panel to both react to the recommendations as well as outline any other thoughts they might have on how our state should proceed in redesigning or realigning our healthcare workforce to meet today's and the future needs. So just a little bit about the commission's charge. It was to develop a strategic plan for building future California workforce with a number of practical short, medium, and long-term solutions for the state, education, and employers to address current and future healthcare gaps, and kind of agree on a cooperative strategy that promoted shared ownership and priorities. I don't think that the commission didn't view that it was just solely the role of state government to meet these recommendations, but had to be in collaboration with the private sector, educational systems, et cetera. And in doing so, would be seeking commitments for effective plan implementation. Obviously, we would be trying to build and align existing efforts, such as those here in the Central Valley and through the community college system, and then act as a private commission with government participation. So it wasn't really, this is not government-driven. The California Health and Human Services Secretary Agency sits on it as the three segments of higher education, but really was designed to be kind of a public-private partnership, and then kind of educate and engage key public and private stakeholders to support success. So building kind of collaboratively on the framework that we already have and kind of moving toward the future. So this is kind of the structure real quick of the commission. There are two commission co-chairs. The president of the University of California, Janet Napolitano, is one of the co-chairs, and the CEO of Dignity Health Systems, Lloyd Dean, is the other co-chair. And there's a variety of technical, then that commission itself broke up into three specific subcommittees. They're there in the green on the bottom to allow for greater in-depth discussions on particular subject matters. And then there's also a very large and robust technical advisory committee that feeds off of that as well to help inform both the work groups as well as the commission itself. So again, all these are designed to kind of encompass the breadth and depth of the healthcare delivery system. The commission has met 6 times already, and staff have released a series of recommendations which they hope to be ratified in January. And again, what you have on the table, there's a series of 31 bulleted recommendations. This is the first time this has been discussed in a public venue before. So you are the first on your block, literally, to see these. Just a little bit about the commission and kind of how they went about their work. As I mentioned before, they were comprised of 3 subcommittees, which are that kind of little Venn diagram over there, as well as a series of foundational elements guiding their deliberations, which are, let's see if I can get the, here it goes, which are down here, some foundational elements to help guide their deliberations, all with the goal of producing the right people in the right places with the right competencies and capabilities to achieve the outcomes you see there on the right over here. So this is a pretty tall order in a relatively short period of time to kind of pull together, but they didn't start from nowhere. They had some strong foundational elements that they chose or hoped to build upon. At the same time, in the considerations, the commission was also taking into account the various influences on population health, I should say, all of which taken together have enormous implications for the future health workforce in California. So this is a little bit more about the context in which they were operating and trying to take into account based on the expertise and knowledge of the people that were on the commission. The current structural context, that was weird. Oh, it's one of these tricky ones. Hold on. There we go, a tricky one. They were also not ignorant of the current structural context of the workforce development system in California. The commission has been keenly aware of the various entry points and pathway examples of success for various systems of education, including the one here at West Hills. So, and Jeff here has a long history of working with health career pipeline development activities, and again, use this kind of as a part of the framing or backdrop of their work. So much so that as part of this work, California's higher education system formed a special work group kind of working alongside the commission to maximize the commission's access to up-to-date information to inform their recommendations. So it turned out that the different segments had never done, at least as far as I know, a complete inventory of all of their health programs that exist both in community colleges, CSU, and UC. So as part of looking at the scaffolding they're trying to build on, they realized, gee, we haven't even talked to each other as much as we need to about this, and have set up kind of a special different group. And I don't know how, I think the inventory, how thick was the inventory? Or which we can probably, I think it's a public document, isn't it? Public? Yeah, so they actually finished the inventory, and I had never seen such a thing either. And again, that was really neat for them to kind of see them kind of working together themselves, trying to figure out where those touch points, where those collaboration points were as well. Again, toward working toward a list of issues and priorities to better feed into the commission's work and come up with more comprehensive recommendations. So in trying to figure out even how they would go about doing the recommendations, they kind of developed a strategy portfolio framework, which I'm not going to go into in great detail here, but there are four major ones that kind of hits all the major touch points that you might expect in looking at kind of a healthcare workforce delivery system and kind of how you want to move toward the future. And then finally, beyond the strategy portfolio framework, they had some prioritization criteria. As you might imagine, there was no shortage of ideas between the commission and the technical advisory group. And so the commission members and staff arrayed the various ideas according to the prioritization criteria they all agreed upon that you see kind of listed here. And then from the various ideas, they boiled it down to about 33 recommendations, which you have in your packets. They were hoping the incoming state administration, private sector health providers, and our various educational segments will strongly consider in building our future health workforce. So now to talk a bit more about in detail about those recommendations will be Jeff.
Thank you, Richard, and thanks to the endowment and the other foundations for funding this timely and important effort. It's really a pleasure to be here with you today. I will say that throughout the process, our commission has had a priority emphasis on looking at the needs of key regions like the Central Valley and the Inland Empire and others, which are some of the largest, most fastest growing regions and the most diverse regions, and some of that have significant and growing shortages. And so you'll hear many of the recommendations that we have are targeted towards how we help you to build the workforce that you need going forward. These are draft strategies and recommendations, so I'm here today to share them with you and to learn from you. As there's still time as we develop our final report and the final version of these recommendations to get further input, so look forward to the dialogue with you today. I've been working here in the Central Valley overall through Health Career Connection, which supports college students to get into health careers since 2008, and partnering with Dr. Catherine Flores at the Doctors Academy and the Latino Center at UCSF Fresno as part of doing that. Dr. Joseph Castro, the president of Fresno State, is one of the commissioners and has been representing the needs of the Valley, as well as Dr. Flores, who is on our management team for this project. So what I'm going to do now is briefly go through what the recommendations are as they stand today in our three strategy areas, and then look forward to a dialogue with you about that. As Richard described, the commission had to boil down all the different possibilities of the workforce to work on in three priority areas, and those priorities are primary care, behavioral health, and care for our tidal wave of older adult population. So it's not that other areas aren't important, but those are the ones that were chosen based on the growing need and based on the existing shortages and based on the opportunities for innovation and the impacting those areas, that impact that has on health overall. And prevention actually was part of the primary care area of focus. And then increasing diversity, increasing health equity, and leveraging technology more were foundational areas. The sheet that you have, all of you should have a sheet that says Commission Strategy Areas and Recommendations. That's what we're going to briefly highlight. The Commission did establish a North Star goal, and this is a goal that was also supported by our technical advisory committees and subcommittees, and it's really about making sure that, and by the way, this is a 12-year time horizon, so this isn't just a set of policy recommendations for the next cycle. This is saying it takes a long time to build the future workforce and address the challenges that we have. And so the idea is that we're putting a stake in the ground, we'll have a master plan for moving forward, and that we'll be working on these strategies over the 12-year period of time. You'll see that some of these are more well-developed. They're more practical things like increasing the number of primary care residencies that we have, and some are more bold new ideas that are going to take a while to really develop. But the North Star goal here is really about making sure we have the workforce in 2030 with the capacity, with the competencies, with the diversity that can leverage technology and work together to really improve health, to improve access, and transform the way that we're doing things. We did go into this understanding that we're not going to be able to produce enough people or within this time frame to meet the needs, nor could we afford it, nor should we, given the advances in technology and team-based care and other kinds of things that are taking place. So with that in mind, we had 3 priority strategy areas. And the first is really about people. It's really about investing in the people of California, investing and providing more opportunity for people from all communities to become part of the future health workforce. And knowing in the Valley, Dr. Castro's talked about how at Fresno State, 90% of the students come from the Central Valley counties and are place-committed individuals who would want, if their opportunities are here, to be able to come back and serve. They have the rich diversity and language capabilities that we need. So how can we invest in more people who are from your areas to be able to become part of that future workforce? And I'll go back and talk about the details of these next. The second area is expanding and transforming the capacity of our educational system and training people with the right skills, because you can get more people interested, but our state has underinvested over the years in terms of its educational capacity to be able to produce enough people and produce them particularly in the right areas to be able to have impact. So we have to, if we're going to get more people interested, we have to build the capacity to be able to get them through the system. And so that's the second part of it. And we have to transform using technology and other things about how we're educating people. And then the third area is to strengthen the capacity and the effectiveness and optimize the use of the current workforce that we have. We have to use technology differently. We have to look at the roles and scope of different players. We have to utilize more community health workers and peer support specialists and home care workers and others in team-based models using technology to be able to meet the needs. And we need to train more primary care providers on how to do behavioral health and deal with pain management and opioid addiction and those kind of things. We're not going to have enough psychiatrists to be able to do that work. So that's the third. So those are sort of the 3 overarching strategies. And within those, I'm just going to highlight some of the specific recommendations. And I will say to you that there's still a lot of different things here because we tried to be comprehensive. We tried to take the input from a number of different players. And there still is more refinement that's needed, more prioritization, and also thinking about how would we sequence these over time? How are we going to pay for these over time? Some of these things, how are we going to politically have them be feasible? Those are still things that are to be worked out. So going back to strategy number 1, which is increasing opportunity investing in Californians from all communities to advance the health professions. And the first part of those are building the pipeline. It's basically saying that we need to have, starting in middle school through health professions school, we need to strengthen exposure, experience, mentorship, academic preparations, parental engagement, psychosocial support. We need to strengthen those things for people from our communities to get into the health workforce. And we have proven programs like the Doctors Academy in Fresno, and that's in Selma, Carruthers, other places that have done that for 20 years and have gotten students into 4-year schools, graduating from 4-year schools. 50% of the Doctors Academy students have gone on to health profession schools, and many of them are practicing here in the Valley. And so that's an example of a program that is not scaled and as sustainable as it could be. Can we scale and replicate those kinds of programs? Delhi has a really great program that they're working on. So how can we look at programs that are in the Valley and other places and help lift those up and help them be larger scale in terms of their impact? We have a new idea, which is to create something called the California Health Corps, which would be more of a campaign to say to people in all communities, hey, we need you in the health field in our state. And these are rewarding opportunities, and you should know about primary care and behavioral health and geriatrics, and you can do well by doing good, in those areas, and try to find a way to and then engage people in programs that are out there to support them, getting them connected to scholarships and other kinds of things that can support them, leveraging technology on a larger scale to connect people to opportunities, and having part of their development as health professionals be doing more service learning kind of work on health improvement in their communities as a way to build their credentials and their track record on their way to becoming health professionals, and then connecting them back to their communities. I know that we were talking earlier about sometimes there's brain drains, that people go other places from the valley and do they come back? So the idea is how can we work harder using technology and campaigns to connect people back to working in this area. So that's the health core. Also investing in health career opportunity programs. Then it kind of comes to scholarships that we have to have incentives for people to go into these. People are not going into primary care and behavioral health and aging careers as much as we need them to, and they're not practicing in the Valley and the Inland Empire and far northern California. So what kind of incentives can we put in place? And there already are proven loan repayment programs that OSHPED and others are operating and are really making a difference. We need to increase the funding for those programs so there are more incentives available for people to practice. And then one thing we're proposing is to create scholarships. Loan repayments really important once people finish and practice to recruit and retain them. But a lot of the feedback we've had along the way is we need to have more scholarships for students, particularly from areas like the Valley, and say that in return for a scholarship on the front end so that they don't have the debt that they're coming out of school, we'd ask for a service commitment, kind of like the military does. They're saying, okay, if you're from the Valley, you commit to becoming a nurse practitioner or a PA and coming back and serving in an area like this, then they would get, if they assuming they follow through on that, then they would graduate without the debt, and hopefully that's an incentive to give back. And so UC Riverside has a program like that with their medical school, and is finding some success in having students from that area get into school without the debt and then planning to practice primary care in the Valley. So those are some examples on the front end of trying to build the pipeline, and then on the back end of trying to provide incentives for people. These incentives are really important in behavioral health in particular, and we've had workforce education and training funding on a statewide level that is now sunsetted, and I know Toby's going to be talking more about this and talking about money at the regional level. But we had $20 million a year that was available for workforce education and training to provide stipends and educational support for people going into behavioral health. That has sunsetted. So now we need to do something to find comparable dollars to be able to continue to fund people to go into behavioral health and to get the kind of training that they need, and to fund residencies, more residencies for psychiatrists and psych NPs and others who are going to do that kind of work. So that's a big part of it. And then within behavioral health, we also want to start promoting behavioral health careers early on. And there's a lot of stigma associated with behavioral health, a lot of not awareness of behavioral health careers and their importance, and not so much people knowing how to get there. So both on the college and high school level, we want to do some large-scale promotion of those careers and supporting people to go forward. So those are some of the aspects of this first one, investing in the people of California. The second main strategy then is to build the educational capacity, transform the way that we're doing it. One of the big recommendations here is we need to increase the capacity of medical schools. But we're not just saying, and it's expensive to do that, but we haven't invested a lot. California has 60% of our students in California go to medical school outside of California, which has been a good cost move for the state because a lot of those folks still come back, right? And that's been a great strategy, but we still need more people from our state to be able to get into our programs here. The capacity here is linked more towards increasing capacity in primary care for people in primary care and behavioral health in particular. A couple of things we have here are supporting a recommendation to establish a branch campus in the San Joaquin Valley of UCSF Fresno, a branch medical school campus. I know that's something that Assemblymember Gray has been really supporting, I think, for a while. So that's on the table here as something that would be put forward from the commission, and I think there's been good support for that. Also establishing things called hometown programs. I don't know if any of you are familiar, but AT still has hometown programs here in the Valley where community health centers can nominate people from the community to be part of a medical school or a PA or NP training program. The idea is, well, why, if AT still could do that, why couldn't UC do that? And UC Davis is interested in doing that, creating a program in which you all could nominate people from your area. Maybe they get some credit for being from a shortage area in the admissions process, and then there would be a plan where they would have scholarships, and there would be an intention to have them do some of their clinical training and residencies back here in the Valley as an approach. Also accelerating medical school. Davis has a 3-year medical school for primary care in addition to, instead of 4, that gets them into residency sooner. So let's produce more people. And there are now more, some states are going towards that as a model. So can we accelerate, expand the accelerated medical programs that we have? We also need to increase residencies. One of the highest predictors of where someone will practice is where they do their residency. And so California also is in the 46th or something in terms of investment in residencies. So we need more primary care, psychiatric residencies, and more of them being in areas like the Valley so that people will come here and stay afterwards. And then we need to utilize the community colleges, I think, more. The community colleges are already such a tremendous source of training people in all these different priority professions. Can we leverage the new online college that's being implemented, which has health as a focus? And can we work with the colleges more to provide more training around community health workers and medical assistants and peer support specialists and home care workers and others that are really going to be important parts of the workforce? And we'd love to talk with you more about how to do that. And then the third and final area is how do we utilize the people that we have to their maximum capacity. And one of the areas that we're looking at is increasing the production and the capacity of nurse practitioners. And nurse practitioners have demonstrated throughout the country more of a willingness to practice in urban and rural underserved areas, more to take care of Medi-Cal patients that in our state, we have more restrictive practice authority for nurse practitioners than other states do. 28 other states have what's called full practice authority for nurse practitioners, which allows them to practice at the scope of practice without having physician supervision. So one of the more controversial issues that is being put forward by the commission is that we would expand to nurse practitioners would have full practice authority, and we would also produce more nurse practitioners and particularly target more nurse practitioners from areas like the Valley. We would also there's also a proposal to produce more psych-trained NPs and have people that are currently NPs working in areas of the state that are maybe in primary care who want to get psychiatric training, allow them to be able to do that and provide a scholarship to do that using technology to allow them to do it. But there's been opposition over the years to NP practice authority, which I think there will continue to be, and it may not be a politically feasible recommendation at this moment in time, but so far the commission has said it's something that is a key part of building the future workforce. The needs are so great in many of our areas that it's time to really put a stake in the ground and say that that's an important thing. Again, it hasn't been decided on formally, but there has been support to go in that direction, and many players, many people are still opposed to that strategy. We also need to utilize community health workers, peer support specialists, medical assistants, health coaches, health navigators, much more in integrated team settings, both in behavioral health, primary care, prevention, using more nurses in terms of population health and more in outpatient kinds of settings. So that's a big part of this. And then also, as I mentioned earlier, training more primary care providers on delivering behavioral health services and dealing with pain management and those kind of things more effectively. And then the last part of this is really two other parts here. One is leveraging technology more, and there's a proposal to establish a health technology center that would coordinate with the telehealth network and many of the other exciting things that are going on to help to say, hey, we should have a coordinated approach to making sure we're aligning efforts to have that technology not only benefit patients, but apply to how we do things differently in the workforce, and how do we maximize the use of that kind of technology. I forgot to mention that focusing on home care workers, we need 200,000 more home care workers by 2030, which is going to be a tall order as all of the baby boomers head towards wanting to age in place in our homes.
We're not getting older.
What's that?
We're not getting older.
We're just, time's just going by. We're not getting older. I like that. And but we have a new idea of creating a universal home care worker, which would be not take the place of what's out there now, but create kind of a more expanded home care worker role with competencies, with certification, potentially with reimbursement that would help that expand. And then with all of this, it's going to take a lot of work to make this happen. So part of the recommendation is to establish a statewide infrastructure that can implement this. Because part of the challenges, as you read in our previous plan, many other states have done this kind of work, and we've done it here before, but there hasn't ever been funding or staffing or a way for it to be implemented. And so this is going to take a tremendous amount of work to pull all this off and make this happen. So having a statewide infrastructure to make it happen, and then to hold accountable and to report on progress and to adjust as things change. And then the last piece of it is developing regional infrastructure that would go along with it. Many workforce needs are more local or regional. So while having a statewide coordination is important, we want to invest in regional structures like here in the Valley, where people, employers and education and workforce development, economic development would come together to say, what are our local priority needs, and document those needs, and then say, what's our plan over time to invest in moving those forward so that we can address those. Pilar and I were talking about how on a statewide level, there's not many recommendations here about nursing, because in a lot of ways, nursing is well supplied at this point. We need more BSNs, we need more diversity in those things, but she said in the Valley, nursing still is a critical issue. So that's an example of how your regional work could be focused more on nursing than perhaps it would be at the statewide level. So that's our overall approach. You can see there's still a lot here and a lot of prioritizing needed, but that's where we are. And the next step will be for the Commission to review a final report and the final versions of these recommendations, and to be able to hand something to our new governor and to also to the other commissioners that are part of this to make it work. And the last thing is that also advocates. We're going to need everybody to run with this. We'll put these out there, and we're hoping that advocacy groups and others will take some of these things and make them happen. So that's where we are. Thank you.
Thank you, Jeff. So I next want to turn to Pilar. As was mentioned earlier, the area of nursing is one of the more controversial areas, and in this particularly as it gets to more independent practice. That's been very, very controversial. And again, you may think these are not radical, but if given some of the controversy on the nursing stuff, it's like way too radical. Even putting together kind of a statewide commission to do a master plan was really a different departure for California. Even that itself was unusual. I think most people just kind of usually throw their hands up. The state's too big, this and that and the other. But again, this is a real, a truly comprehensive effort to try to put everything down on paper and kind of get us kind of going and oriented all in the same direction. So, Pilar, if you'd like to share any of your thoughts about either recommendations or where you think, where is radical surgery required?
Well, I definitely believe that the Central Valley is hurting, and the report that came out, and it's actually in your packet, talks about how in most areas of the state, nurses by 2030 they'll have the number of nurses that are needed for the patients. The one issue that we have there that's not mentioned so much is diversity. We need more diverse nurses and healthcare practitioners because of our population. The last count that I recall was that the population of Hispanics in the state was like 50%, yet the number of Hispanic nurses is only like 9%. In this area here, a little bit lower across the state. So while there is, we have nurses, we need more diverse nurses. But in the Central Valley, we really have to look at that. So that's my comment in regards to responding to Jeff's notes. Do you want me to go on with the presentation? Okay, so if we can move on to my presentation. Thank you. I bring you greetings from the California Board of Registered Nursing. I want to thank you for inviting me to speak. Thank you, West Hills, and it's an honor to be here and share information with you about our board. I was appointed in October of 2015 by Governor Brown in the role of nurse administrator. As I'll tell you about the different roles in a minute. But it's been an honor to be able to serve, and particularly being from this area and being able to focus some of the issues on our area here. Next slide, if we have the clicker. Yeah. So what is the board and its purpose? It's a government agency established to protect the public by regulating the practice of registered nurses. A lot of people think that the California Board of Registered Nurses is there to protect nurses. a lot of nurses are misguided that way. But it's actually not. The board is there to protect the public, to make sure that we have qualified nurses that are following the regulations and following the standards of practice, to make sure that we are giving the patients the safe, quality care that they deserve. So the board is not there for the nurses, but it's there for protecting the public. The composition of the board is basically 9 members. 4 of the members are public members, and 5 of the members are registered nurses. I've had nurses, people say to me, well, why is it that there should be more registered nurses? They should all be registered nurses. And I said, no, remember what the purpose of the board is to protect the public. So we currently, we're minus 1 member, one public member down right now. There's only 8 of us right now, but that includes 2 direct patient care providers. These are nurses that are actually working as staff. There's 1 advanced practice nurse provider, a family nurse practitioner or advanced practice nurse. There's a nurse educator who has worked in education, is aware of the regulations, and there's a nurse administrator who I really hammer people on the Nurse Practice Act when they come before the board. When I started working on the board, I thought that what I would be seeing was a lot of issues with regards to negligence and incompetence, and I'm glad to say that that is not the case. But I am sorry to say that most of the issues that we deal with are nurses who drive under the influence or unfortunately have problems with addiction to opioids, and consequently end up losing their license or being placed on probation. And that's really sad to me. And it makes me wonder, why is it that these nurses suddenly turn to drugs and alcohol? Is it the pressures that they are under? Is it the situation that nursing is a stressful profession, but why is it that we see so many of them that are getting placed on probation or having their license revoked because of drugs and alcohol? 7 members are appointed by the governor, and 2 members are appointed by the legislature. As I said, I was appointed by Governor Brown. We serve 4-year terms. My term will be coming up in June 1st of 2019. I do not plan to seek reappointment to the board at this time. So I'll be looking. I'm going to try again. But I would like to see someone from the Valley step up to that position. When I first got on the board, I said they never had meetings in the Central Valley. They were always either up north or down south. And I said to them one day, I said, you guys are coming to Fresno. And they said, no, we're not. I said, yes, you are, because I'm not going to let down until you do come to Fresno. I'm proud to say that they've now been to Fresno twice. They were just in Fresno in October. This gives our nursing students and our nurses the opportunity to see their board in action. And particularly for the students, the great learning opportunity. The schools were all invited to send their students, and we had about 160 students that came to the board meeting in October. And actually, I've often asked the petitioners who are there to get their license back to share with the students what they need to be aware of. How do you keep your license, and how do you stay out of trouble? Because that's really important. So next month we will be in Monterey, so we are starting to move in different places that we haven't been to, so I'm happy about that. These are the current board members. I don't know that you can see them. Trandy Phillips, who is a direct patient care provider, is from Northern California. That's what the NC stands for. Donna Gerber, who's the vice president, is a public member from Northern California. Donna has served on the medical board, other boards as well, so they're well versed on government agencies. Elizabeth Woods is our nurse practitioner. Michael Jackson from San Diego area is the nurse educator. Cynthia Klein from Southern California is another direct patient care provider who works directly with patients. Barbara Yaroslawski is a public member who's also been very active on different commissions and boards. Imelda Sehabekowitz is a public member from the Bakersfield area, and yours truly is from the Central Valley, and I said I'm in the nurse administrator role. So this is our current board. And you can go to rn.ca.gov and look at the board. It posts the meetings there, when they are, where they're going to be. It provides a lot of information on different forms and publications that they put up, regulations that are up and coming. We are often criticized because our board is not part of the compact states. The compact states, there's certain states in the United States that are considered compact states, and they pretty much makes it easier for nurses who move to different states to just get their license. California is not a compact state, and the reason that we are not is because California is very regulated. We insist that every nurse has their fingerprints done. This wasn't the case a few years back. But we don't want a nurse from one of the compact states who maybe isn't fingerprinted to be licensed in California and turn out to be an axe killer or whatever that we haven't vetted. We're responsible for making sure nurses are safe to practice. So that's why we are so diligent about that. We hold our meetings monthly, except for July and December. The meetings are open to the public. The first day of the meetings is always discipline with the students, that we invite the students, but it's when petitioners come forward to ask to have their license either gain their license back or have their probation shortened. We get to ask questions of those petitioners, and we spend some very long day then, because then we go into closed session to decide on the fate of these individuals. Whether we're going to give them their license back, whether we're going to hold them back because we don't feel that they're ready. There's some people who have had numerous DUIs that have come before the board, have not gone to Alcoholics Anonymous, have not gotten a sponsor, and don't consider themselves an alcoholic. And they're asking for their license to be given back. So we have a responsibility to make sure that we feel that that nurse is safe to practice, and so consequently, we do not always give them their license. We oversee the practice of over 450,000, it's getting closer to 500,000 nurses. So we have a lot of work to do, a lot of work on our plate. We approve all the nursing programs that want to provide nursing, that want to start a school of nursing. We have real strict criteria in that we believe that the clinical component and the theory component need to go hand in hand. And some of these programs that are out there, particularly in the private school programs, do not have that. Some school in New York who basically says, you don't need a clinical component, you just need the theory, and you come for a weekend and we'll check you off, and if you can do it, then we'll sign you off to become an RN. Well, we don't feel that that's safe for our nurses to work that way. We want them to have the clinical component. So we evaluate the licensure applications, we issue and renew license to practice certificates, and we take disciplinary action when necessary. We had a nurse, as an example, who went drinking with friends. They had a little bit too much to drink, so she knew to call Uber to take her to the next bar because they were going to continue drinking at the next bar. Decided she'd had enough, so just called Uber again to take her home. So she did all the right things. Her friend decided to stay behind. Her friend calls her about an hour later, says, my car won't start, will you come pick me up? So instead of telling her, take Uber like I did, or take a taxi and I'll pay for it, she gets in her car and goes to pick up the friend, and on the way home gets stopped. So now she's got a DUI, now she's on probation. And probation isn't cheap. It costs you money because you have to do testing, drug testing particularly. You have to do a lot of things, and it's not, your job is in jeopardy sometimes because you have to be monitored, and a lot of people don't want to do that. So we tell students, this is your livelihood, protect your license. We work with schools and hospitals and healthcare agencies to determine the need for registered nurses. How many nurses are we going to need? How many nurses do we currently have? How many are going to retire? The baby boomer nurses now, we're all retiring, hopefully. And, we're going to need nurses to replace And we work with UCSF to produce a biennial report that gives us the needs, the forecast, the needs for nurses for the future. And that report, again, is on that website that you can look to. As I said, we have a projected shortage for the Central Valley and Sierra regions by 20% by 2030. So that means that we need to get working here in the Central Valley with programs that will encourage young students to go into nursing. I don't want to be sitting here in 2029 thinking, oh my God, what are we going to do? We have to start now to start planning and planting the seeds in those students that, to get them to go into nursing, because that way we'll have enough nurses, hopefully, to take care of everybody. I want to make sure that when I'm in the hospital and I need a nurse, there's going to be one available that can take care of us.
Just don't get hurt in New York.
That's right. So we want to make sure that, we have enough nurses. There's a rapid population projected for the Valley, and so we must keep up. Right now, we have a younger workforce in the Central Valley, and that's good for us as compared to the rest of the state. That means those nurses will hopefully be in longer. We'll have a longer period of time for them. So the Central Valley is fortunate in that way, in that we have younger nurses. However, our inflows, meaning nurses who graduate, nurses coming from other states into California, from other countries, our inflows are 1,830 right now, and our outflows are 2,703. So there's a discrepancy there in terms of the numbers the nurses that we're bringing into the states, either through graduation or moving here, versus the nurses who are retiring or moving out of state. So we're in a negative flow right now here in the Central Valley, which we need to address in terms of how do we make sure that we have the nurses. And there's programs out there that CNCC, Careers for Nursing in California, has slides that are available that you can use if you want to go talk to students about nursing. They're set up for grade school, junior high, and high school. Kaiser Permanente actually did this project. One of their nurses who was working on a master's program or a master's degree actually did this for us and put it together. So there are tools available out there to utilize when you go out, or you have people going out to speak to students about going into nursing and what they need to do and getting them excited. We had the radiologist at Community Hospital while I was working there. His daughter was going to school up in Washington and was going pre-med. That was the route. So she was going to be home for the summer and said, Pilar, my daughter's going to be here this summer. Would you mind talking to her about nursing? Tell her what nurses do. I said, sure, I'd be happy to. So I spent the day with her, talked to her, showed her around, talked about the different classes and what nurses do and all. At the end of the day, he calls me up and he says, Pilar, what did you do to my daughter? I said, why? She doesn't want to be a doctor anymore. She wants to be a nurse. I said, well, that's good. That's good. So, if you basically talk to people about nursing, show your enthusiasm, and get them to take an interest in nursing. A lot of people haven't even thought about nurses, being a nurse. So we need to take and invite them in, particularly men. We need more male nurses as well as minority nurses. They're considered a minority. So nurses are going to have new roles as we move to more of a wellness model versus a sick model. There's going to be more clinics, outpatient clinics, and outpatient ambulatory services that we're going to need nurses for. They're opening the door. And we need to work with our schools to start educating nurses differently. Right now, the model is strictly for acute inpatient care. Very little is directed towards outpatient, ambulatory. So our schools need to get on board to start educating nurses, student nurses, for the outpatient environment. And these are the new roles for nurses that are being suggested: care coordinator, faculty team leader, informatics specialist, community nurse, and primary care partner. These are you'll be seeing these as new nursing roles in the future. And again, the BRN website, rn.ca.gov, has a lot of information about the need for nurses, the steps to become a registered nurse. It talks about minorities and men in nursing, and also how to file a complaint if you have a complaint against the nurse. It talks about how to do that. So I hope that's given you some insight in terms of what the role of the board is. I'm very proud to have been able to serve on the board for the past 3.5 years, and if anybody's interested, talk to me, and I can put in your name. Thank you.
Thank you so much. Now from a perspective from behavioral health, Toby?
Thank you very much. So my name is Toby Ewing. I'm the Executive Director of the state's Mental Health Services Oversight and Accountability Commission. And I want to recognize that the work that Jeff and the Health Workforce Commission has done has highlighted behavioral health as a core policy challenge. We don't have to go back very far to recognize that the tremendous stigma around mental health, or we often refer to behavioral health, which deals with addiction issues as well, is so present in our communities that when we talk about healthcare, we often forget about psychiatry, about psychology, about areas of practice that really touch upon people with mental health needs. So I think we're thrilled that under the endowment's leadership and the support of the other foundations, that behavioral health is up there with other health issues. Like healthcare, more broadly defined, we see tremendous challenges in terms of the design of our mental health system and the mental health needs in our communities. And so I want to talk a little bit about where we are in terms of policy, talk a little bit about some of the initiatives that we are working on, and I'll give you a very quick overview of who we are and what we do. And then I want to challenge you, and I'm going to show you some data that is relevant to Fresno County to try to set the stage for the afternoon's discussion about action opportunities. So we are a mental health commission. We don't run mental health in California. We have another state agency that oversees our mental health system and is really the lead implementing agency. That's our California Department of Healthcare Services. Our mental health system is really run by the counties. So in this community, Fresno County is your lead mental health agency. Anybody here from Fresno County Mental Health?
I work in an ED in Fresno County, so we do a lot of work.
Okay, there you go. All right. That's right. Okay, we won't burden her with being responsible for all mental health decisions. But thank you for bravely raising your hand and for being here. So we're like a mental health grand jury for the state of California. The commission is an independent entity. It includes the state attorney general, the state superintendent, a state senator, a state assembly member, and then we have 12 members appointed by the governor. And 2 of our members are local. Lynn Ashbeck is a city council member in Clovis, and Renita Anthony is one of the commissioners, and she's from Fresno. And we also try to get down here. We travel. We're in Riverside next month for a full-day commission meeting and then a full-day strategic planning meeting. So the commission's job is to implement and support transformational change in mental health as defined under the Mental Health Services Act, which was passed by the voters in 2004 under Proposition 63. And so if you saw on the ballot, if you voted recently, you saw Prop 2, which would authorize the use of mental health funds to support supported housing. And so those are mental health dollars that will be used to fund, make investments in housing opportunities to deal with our homeless challenge throughout the state. That's all part of the Mental Health Services Act. But there's a couple of key components of the Mental Health Services Act that we're really excited about that are very atypical. They're unusual in public policy around the country. They're actually unusual throughout the world, and they create tremendous opportunities. The Mental Health Services Act, in addition to setting policy, creates a 1% surtax on incomes over $1 million. So it generates about $2 billion a year specifically for mental health. Our entire mental health budget annually is about $8 billion. So about 25% of this money comes from this special tax. The nice thing about the special tax is there are very few restrictions on how the money can be used. But there's a requirement that counties, most of this money goes to the counties through a sort of a monthly direct deposit. So it's really in your county bank account. It's not in my bank account. I don't write the checks. Please remember that as I'm leaving. I don't write the checks. There's a requirement that 20% of these funds be set aside for prevention and early intervention. It's about $350 to $400 million a year. That's a tremendous amount of money that must be spent on prevention, early intervention. And again, we don't see that in Medicaid. We don't see that in Medi-Cal. Very few states have a mandate, a requirement, that our systems really focus on prevention, and that's what makes it unusual. And so I think there's this, the way I describe that is there's this recognition that our healthcare delivery systems quite often focus on the deep end response to illness. And this body of policy says, hey, you must set aside 1 out of every $5 to move upstream, to begin to recognize things like social determinants of health, which is one of the issues in the recommendations, to begin to recognize the impact of trauma on children and families and how trauma begins to affect your mental health and well-being. And the Prevention and Early Intervention language of the Mental Health Services Act also defines mental health very broadly. It says the things we're trying to prevent are school failure, homelessness, unemployment, the removal of children from their homes to the child welfare system, suicide. So we often, and prolonged suffering, there's a criminal justice involvement is another one. There's 7 key negative outcomes. The reason I mention those is quite often we think about mental health, we think about the clinical care that you would receive in a hospital environment, in an ER, or with a practitioner with some sort of a license. Could be a nurse practitioner, could be a psychologist, could be a marriage and family therapist. But the Mental Health Services Act says this is really about well-being. This isn't about illness. This is about how do you use this $350 to $400 million a year to make investments that support quality of life in your community. And counties have very broad discretion on how to use this funding. Your behavioral health director, Duan Oltek, she's a phenomenal leader. She more than many of the directors really understand, because of her personal professional background, really understands the opportunity for prevention and early intervention. But I want to put that on. I'm going to show you some data about some of the money that's available. So I want to emphasize that as you think about the recommendations that are coming out of this commission, as you think about what the opportunity here is for the community college district, for the county, for your school district partners, for your healthcare agency partners, the Mental Health Services Act says use this 20% of the funds for things that are really going to prevent the initial onset of a mental illness or the escalation of a mental illness, and you have very broad discretion of how to use those funds. As exciting as that is, there's also a 5% set aside for innovation. That's about $100 million a year. Although counties make decisions about how to spend those dollars, the innovation plans have to be approved by our commission. We allow counties to tap into those dollars across 5 fiscal years, which means there's $500 million for mental health innovation in California. I spoke at an event, a global event in Mexico a couple of years ago, and I mentioned this, and a woman came up to me and she said, I'm part of China's National Mental Health Institute. You have more money than we do. Can we have some of that, right? So, unfortunately, I had to tell her no, but it's the recognition that California is in this very unique position of having resources to try things that are very unusual, very creative. The innovation component of the MHSA, again, it requires a 5% set aside. Counties can do just about anything they want with those funds as long as they can make the case that it's connected to mental health. You can't invest in an evidence-based practice in an evidence-based way with the population where the evidence base was developed. But you can adapt an evidence-based practice. You can use these funds for workforce strategies, for educational strategies, for outreach. And so we're seeing counties do some phenomenal things. So although, in terms of our behavioral health system, it's very clear that we need more psychiatrists and we need more child psychiatrists. We call those pink flying unicorns because they're so rare, right? So, but we also need more practitioners who are working at the community level. LA County recently had approved a very exciting innovation where they're equipping vans with telehealth capacity and they're having community workers in the van with psychiatry on the other side of the telehealth piece. And the vans they're bringing mobile care to homeless individuals with high-end behavioral health needs. Not trying to bring these people into clinical care, but trying to bring clinical care to people who have needs in the community. They recognize that we have to do a much better job meeting people where they are. And that's less and less about creating clinical practice and more about creating community practice. We are currently writing the suicide prevention plan for the state of California. And in these conversations, we're hearing more and more that children as young as 4 and 5 and 6 years old are starting to talk about suicide. The response to that is engaging our child care workforce. It's about engaging our teacher workforce. It's about engaging our primary care workforce as well. And so although there's a foundational need for high-end jobs in terms of psychiatry, we're seeing much greater opportunities in terms of building out the capacity to leverage the broader community to talk about mental health to deliver care in ways that are responsive, again, where people are, whether it's home-based care, as Jeff mentioned, in terms of one of the recommendations or draft recommendations, in terms of these mobile kinds of strategies. We've done some work on crisis services in California, and we recognize, we've heard horror stories of children. We just heard a story of a child who spent 30 days in an ER. It took 30 days to figure out not what the child needed, but how to deliver care to this child. What was tragic is this is a child who had recently arrived in the country. It sounded as if the child and the mom came straight from the airport, getting off an international flight into UCSF, Children's Hospital in Oakland. And in order for that child to be able to access care, the mom had to give up parental rights. When you give up parental rights, you don't get them back. But as a condition of being able to access the care in our state, and imagine what that means to a parent who's just emigrated to this country, just horrific, tragic. But it took 30 days to deliver care. In other states, we're actually designing a service delivery system that is much more mobile, where we're equipping mobile homes, motor homes, to actually park on your front lawn and spend 30 days in your household with your family supporting you. And these kinds of positions are highly trained, technical positions who have access to the medical care that they need to support them, but not necessarily the medical training of being a psychiatrist or a nurse practitioner. And so we see tremendous opportunity in the future in terms of rethinking how our mental health system is designed. We're doing some other things that we want to put on the table if you're interested. Because the money requires counties to be innovative, and because our public sector system is not who you necessarily think of first when you think of the most creative, innovative folks. No offense to present company or anybody else out there. I would include myself in that distinction. Last year, we partnered with Google and others in the tech sector to host a mental health innovation event. We were criticized because it didn't focus on youth. And so we're currently in the process of organizing a youth innovation event that is targeted towards youth and young adults between the ages of 13 and 25. And what we really are trying to do is listen to young people, and we'd love to partner with the community college district here and other local officials and organizations. We want to understand, what are your needs? How can we begin to think first around the needs of the individual, and then use the flexible funding that is available to really shape that conversation and redesign our mental health system to be responsive to the community? Again, recognizing the need for the very traditional clinical kinds of approaches, but understanding that emergency rooms are horrible places to be when you have a mental health crisis, right? They're not calming, right? There's as much compassion and empathy, but these are very hectic, fast-paced environments that really don't lend themselves to crisis stabilization and crisis response. So I want to show you something that we've developed. The Mental Health Services Act requires, he's going to do it all over there, yeah. The Mental Health Services Act, can you go to the top, please? Mental Health Services, we're just kind of riffing on this because after hearing some of the discussion earlier, we thought we would show you this. The Mental Health Services Act requires counties to have a community planning process. In other words, you're supposed to be part of the discussion of how to use the money. If you've been paying attention to mental health, you might have heard that there's lots of unspent funds. And so this is a live shot of our website. There's something we've developed called the Fiscal Transparency Tool. We are working to create tools that first allow you to see how much money comes in for mental health services, how much money is spent, and how much money is in the bank. The second piece is how the money is used, and the third is the outcomes achieved. And the purpose for those three buckets of information is to support your ability to have an informed dialogue with public officials about your mental health system. Are the dollars being spent in ways that are aligned with your priorities? Are you getting the biggest bang for the buck? Is your county pursuing the kinds of programs that are important to you, and what is everybody else doing? This is actually very hard to do. So the first step is the funding. I've got 3 minutes, he says. The first step is the funding, and so if you scroll down a little bit, so all the counties there, you can click on individual counties, and we'll show you Fresno just for kicks, and Juan will call me and say, what in the world did you do, Toby? Because in order to make it big, it's top and bottom. And so total unspent funds, the blue line is revenues over those 5 fiscal years. The orange line or gold line is expenditures, and the gray line is unspent funds. So what you can see, what you really need to take away from this, and these funds are, these reports are in arrears, so they're 6 months after the close of the fiscal year, but you can see statewide that the state is running a surplus. If you look at the percentage, we're not spending 100% of the money. In fact, we've got between 1 year and a year and a half worth of cash in the bank. And I've spoken to county boards of supervisors, and I say I'd love to have 18 months of my annual revenue in the bank. Wouldn't we all? But not if our children aren't eating, we're living in our car, and we don't have health care, right? And so the trade-offs between sitting on the dollars and spending the dollars are the conversations that we are trying to encourage you all to have. So, and it's important to recognize that of the $2.4 billion, it's not as if some of that money isn't encumbered or spent. You know, you need to drill down a little bit. And so if you go up to the upper left, a little tab, so CSS is core service funds, and then PEI is prevention and early intervention funds, and so you can see 151% there. And then the wonderful innovation funds, and watch what happens here. So there's a variety of reasons why innovation funds are harder to spend. Again, being innovative is difficult. The primary reason is that the state signaled to the counties that if you don't spend the funds, that's okay. The law actually says you have 3 years to spend the money or you lose it, and the state has, because of lots of regulatory struggles, the state has not been enforcing the reversion rules. And so this large surplus has built up over time. Let's go to Fresno. So we are working with the counties. So are you on the total? Yeah, so here's Fresno County. So Fresno County gets between $30 and $46 million a year. It spends between $28 and $40 million a year over the last 5 years. Again, we don't know what the current balance is, but our purpose is to inform you all so that you can, as you think this afternoon about what's the action agenda. So the law actually requires counties to fund at least one strategy on workforce education and training. There are funds that are specific to workforce education and training. They're included under the other MHSA. They're not broken out. We just haven't gotten to that yet. But the law actually allows the counties to shift some of their CSS funds specifically into other purposes, including workforce education and training. So the reason we put this on here is we want you to use it. We want you to talk with your county supervisors and your behavioral health director and think about how can you best use these funds to address some of the needs that you have. You can use these funds for loan forgiveness. You can use these funds for scholarships and stipends. You can use these funds to, especially the innovation funds, for creative approaches to training people to be a resource for the community mental health system. You can use these funds for surveys, research projects, new approaches to innovation. And again, I've mentioned some of the innovations where counties are moving towards mobile mental health approaches that really are tapping into the diverse array of skills for people who are coming out of our community colleges and coming out of some of our four-year schools. And so I think Pig is saying, okay, 3 minutes was 8 minutes ago. This is on our website. It's called the Fiscal Reporting Tool. We are going to show you, we will release in about January a similar tool where you can see all the programs in Fresno County. You can see how the money got spent. You can see that relative to other programs. I'll be here throughout the day. I'm happy to talk with you more about it. But please take advantage of the resources that you have and the creative opportunities, some of the recommendations that were put forward, and we'd love to see Fresno lead in terms of addressing some of these issues. Thank you very much.
Thank you, Toby. So we've heard a lot about the use of technology in the various conversations or the previous panelists, and we have an expert in that area as relates to telehealth. Eric, take us home.
All right. Do I have more than 3 minutes? Okay. I don't need that long. Hi, everybody. So I'm going to address some observations with regards to rural workforce development needs based on our, I guess, real-world experiences as we work with a lot of rural healthcare providers, both clinics and hospitals. Can I have the clicker? Thank you. The one with the piece of tape on it, huh? Okay. So for those of you who aren't familiar with the California Telehealth Network, it was operationalized back in 2010 by UC Davis Health Systems, and then spun off into an independent nonprofit corporation, 501c3. About a year ago, we merged with a similarly missioned organization called OCHIN, so you'll see the two terms used interchangeably. I am the president of the California Telehealth Network, which is based in Sacramento, and you can think of us as kind of a division of OCHIN, which does electronic health records and other kinds of health innovation initiatives. We serve over 120 unique customers or organizations in the state of California. We have actually provided broadband connectivity to over 300 clinics and hospitals around the state. These are safety net clinics and hospitals in both rural and medically underserved urban areas. And in addition, we work with hosted electronic health records, both Epic and NextGen, also in the ambulatory environment, so in clinics and hospitals. We also operate the California Telehealth Resource Center. It's one of 12 HRSA-funded resource centers that are charged with providing information, education, implementation of telehealth and telemedicine policies for all California healthcare providers and organizations. So I'm saying now all that to say we're a unique organization in that we actually have active relationships with rural healthcare providers all over the state. And we actually visit these folks on a weekly basis. I'm in rural clinics along with the folks in my organization. And so because of that, very often we end up doing things like staff augmentation. When there is a gap in their capabilities, we get invited in sometimes to kind of help fill that gap until that vacancy can be filled. Kind of gives us a unique perspective in terms of what kinds of skill sets are of highest demand in rural California. And so what I'm going to share with you are observations based on our experiences and also from talking to some of our rural healthcare partners that we serve in terms of what they think. The long term, and this will echo the things, thankfully, that you saw in the report. So you're not going to see anything, I think, that's diametrically opposed, although you will see things because of what we do that are also more from a technology perspective as opposed to just a pure healthcare perspective, and they're related. The first thing that people say to us about what they need in terms of tomorrow's or the future rural workforce needs is competency handling data to improve patient outcomes. So because we're moving to a value-based care delivery system, it is no longer acceptable just to be able to treat the patient and get paid on the procedures you performed. Increasingly, it's going to be about are the patient outcomes improving? And that is a new skill set, if you will, a new way of thinking that has to be incorporated into how the workforce engages with patients. The second thing is, in general, clinicians are going to need to be more comfortable handling technology. This doesn't mean you need to be able to write code, okay? It's not that kind of thing. But certainly from the standpoint of the nurses and the clinicians, the docs, et cetera, we're seeing that there is a higher demand for them to be at least comfortable handling things like video conferencing or other kinds of cloud-based applications, much more so than what has been the case in the past. And then operational expertise in a clinic environment. So I can't tell you the number of times I hear complaints about folks that are showing up in these rural clinics and they've never been in a clinic environment, and having to get them oriented to what that means. It's different than a hospital environment or a health system environment, especially in rural. There are some specific positions that every day we see a need. The first is for telehealth coordinators. In rural California, I told you that we've connected over 300 hospitals and clinics. I would say on a monthly basis, and we do surveys with them, excuse me, generally about 200 to 230 of them are doing telemedicine of some sort. Could be live video conferencing, video consultations where they're beaming in a specialist who's not in the community, but maybe at an academic medical center, or maybe at a remote location. In some cases, it may be using e-consult, which is basically secure messaging, so that the primary care doc is able to consult with a distant or a specialist at another location asynchronously. But in any case, what we're seeing is that there's a need for someone to be the clinical operational champion at the clinic or hospital, and that's usually the telehealth coordinator. We actually, the telehealth resource center that we run does training around the telehealth coordinator concept. We actually participate in grants with the California Healthcare Foundation that are designed to, at some level, fund telehealth coordinators for rural clinics and hospitals, and also fund their training and orientation. This is a role that will continue to be key going forward, because as long as we have a situation where the demand exceeds the number of doctors and where the doctors are not necessarily located where the demand occurs, you're going to need to increasingly use virtual care. And someone needs to be competent enough to, again, be comfortable with the technology to make that happen. And that tends to be the telehealth coordinator. The other major need that we haven't talked about a lot today is technical staffing. So you cannot run a hospital or clinic today if you do not have broadband. You need that for the electronic health record. You need that for an array of hosted applications that are in the cloud. Could be patient imaging, could be other kinds of applications. And generally in rural California and in rural America, just as we have a tough time recruiting clinicians to serve in these areas, we're having a tough time finding the technical talent. And I've listed some of the certifications and specific skill sets that are necessary. A lot of the work we do at the California Telehealth Network is augmenting what skill sets are not available at our rural sites in these areas. So as you think about the workforce of the future, these are things that we're going to have to come to grips with. And for those of you who have been watching what's been going on at DHCS and CMS with regards to telehealth, you will know that recently the good news for us is there's been an expansion in coverage for telehealth consultations. And there's been an acknowledgement, I think, that beyond the bricks and mortar facilities, the clinics and hospitals, which is where telemedicine historically has been performed, there's a need to go into the home or to where the patient is located. So patient monitoring and those things are going to be increasingly supported with Medicaid and Medicare reimbursement. Well, as that happens, the comfort level of the clinicians in using this technology will have to expand. The last point is really around collaborative care. You've heard, or the team-based approach. You've heard previous references to that today. There are many, many situations where we're seeing a lot of our rural multi-site community health centers or critical access hospitals really having to address this cultural change, and they're doing it in various forms, but through things like leadership training and other things that help people to understand that, that the way we're going to deliver care in the future, you're going to need to collaborate with others, and that's a skill set, again, that folks are going to have going forward. I think long-term, you're going to hear more about informatics and population health kinds of things. Reevaluating clinical workflows. We're spending a lot of time, because of the integration of technology and population health, we're having to work with our organizations on reevaluating how the clinical workflow unfolds. And then the community health workers is an important part of where we're headed, with the Pomodoros or other community health workers. We are actively doing work with social determinants of health and trying to identify the right community-based organizations that need to be leveraged in order to address things like homelessness and poverty and employment and those kinds of things. This will become an increasingly important part of the healthcare delivery ecosystem. And what we're seeing today, I will say, is that in many cases for us, it's not necessarily the clinics or the hospitals that are getting into that, but the health plans that are covering their patients. So here are some of the staffing barriers. I asked this question that we're hearing about, and lack of broadband is generally at the top of the list. And the reason for that, and a lot of what we hear when we hear about this is it leads the clinicians to feel like they're they are isolated. Okay, that they're not able to collaborate with their peers and keep up with the latest developments in terms of what's going on. And again, as the standard of care moves towards, value-based care, broadband is a part of how those connections are made. Lack of access to clinical specialists. I mentioned peer contact. Continuing education. So the second most prevalent use of our network, our broadband network across the 300 plus clinics that we serve, is actually for CME, grand rounds, or some form of education. Makes sense if you're in a rural area and you can't afford to take the time to travel to the big city to do the training or the expense. To the extent you can do that from your local community over a broadband connection, that's a big deal. And then, of course, local lifestyle and employee issues. So, one of the things I hear from many of our rural sites is, if we can home grow our talent, identify folks in our community that can be educated and trained in healthcare careers and have the logical career paths and ladders, that's a preferable approach for us than trying to parachute folks in from somewhere else and have them fit into our local community. Now, I've seen successful instances of both, but I'm sharing with you the observations that we most commonly hear from our rural sites and locations. So I think I made it within, I didn't make 3 minutes, but within a reasonable period of time. I'll be here for the remainder of the day and welcome any questions or thoughts.
So I'd first like to have a big round of applause for all of our panelists here. According to the resumes, they have about 140 years worth of combined experience on healthcare, I think. So we do have time for some questions between now and noon, and we will make sure we do not get in the way of between you and your food, because that's always a very dangerous thing. And I understand there will be a walking mic or something, or So if you want to start here, and then I've set up and identify who you are and if you represent an organization. And I don't know if we have a mic or not. Or maybe this is a small enough room we don't need one? You got it over here. Okay, sorry. Kathy to the rescue as always. Yes, sir. Please, your name.
Ken Stoppenbrink, Deputy Chancellor for the West Hills Community College District. A couple observations and comments for Pilar. We have had similar issues with respect to diversity recruitment, especially in our faculty ranks in the Hispanic. What we found is that the pipeline in the USC and CSU systems pumping out mastered levels for faculty is just not there to support that. However, we've done pretty well in our administrative ranks as well as our classified ranks. But faculty is the problem. I was curious if whether or not is that where you see the bog down occurring. And also, secondary to that is that in a different lifetime, 3 or 4 decades ago, where I worked in healthcare, 85% of the workforce were female. Have you seen that switch a little bit more? You mentioned men as a shortage, so where are the numbers now? Thank you.
Good questions. Thank you. Yes, recruitment of faculty for nursing has been a real issue. We've had to do some of our own educational programs to get more faculty. If you don't have faculty, you can't teach students, and that's been a problem. And I think one of the things that we need to look at in the future is some joint appointments where the hospitals and the universities work together to get faculty. That's what we did with the Paradigm program. It wasn't called joint appointments, but we had hospital staff that got some education in order to train in the clinical areas. So I think we need to look at those kind of programs to get more trained faculty. As regard to your second question, we have had an increase in the number of men. I think we're now up to about 13-14% of the workforce is now men, and it keeps continuing to grow, which is great. We were down to 6 at one time. So that's a really good sign that we're seeing more men in nursing. And interestingly enough, when you see how the health fairs, a lot of times our recruiter would say that if the guys came in groups, they wouldn't ask so much about, they'd hear what she had to say, but then the ones who were really interested would come back later by themselves and talk to the recruiter because they didn't want to talk in front of their peers. But they would come back later and get information.
Some covert recruiting there going
That's
on.
right.
Yes, ma'am, in the back. Your name and
Hi,
represent.
I'm Lorraine Smith. I'm the Dean of the Allied Health Programs at Fresno City College.
Great.
And I hear some of the things I'm hearing is a need for some community health workers, home health workers, medical assistants, dental assistants. Those are all low-pay, low-wage jobs. And from our perspective, the community college funding is really being targeted for improving living wages and high-paying jobs. So you have the high-paying, the nurses and the doctors at one end, then you have the really low-paying and not much in the middle. And I don't know if there's any strategies to try to bring, it's all part of the economics of healthcare, but I really see a challenge in not having the incentives to train those workers that are needed because of our funding models.
Jeff, you want to talk about career ladders at all?
Sure, yeah, that's a great question. It's one of the challenges that we're still wrestling with. One of the reasons we came up with the universal home care worker idea is because that could be an additional career classification and part of a career ladder that hopefully could allow people to move to a higher wage over time. But it's still a challenge because many people will start out at a lower wage, and there's a lot of turnover, and will they stay with it? In both the peer certification, peer for behavioral health, and then also in looking peers for behavioral health, part of this is to get them to be reimbursed, to be certified and reimbursed, and so the funding's available for that, which might help enhance the payment there. And then for community health workers, the idea there was to help. We didn't go as far as saying that they should be certified, which many states have done, but it's more that there should be certifying the training entities and the competencies that they have, which hopefully will then, and then also educating health systems and others who might be hiring them about what they can really do that might lead to higher wages for them. But it still is going to be a challenge because the need is so great in those areas, and it's so expensive to live in this area. And in your case, you don't have the incentive train them. So we also have to look at using technology and other kinds of things combined with more clinical training sites to be able to meet that need as well. So it's a key problem, but we're trying to go in that direction.
Thank you all so much for sharing your expertise with us.
I know where you work, but give us your
my
name.
name is Michelle Wallace. I am an emergency department nurse at Clovis Community Hospital, and I just recently joined the faculty at San Joaquin Valley College for labor and delivery and med-surg. So actually these questions will be, it's one question really, but it involves Pilar, Toby, and Eric. With the development or possible development of an accelerated MP program geared towards mental health, will the option be there to use telehealth and mobile clinics as clinical hours for these nurse practitioners, specifically in mental health?
Well, I think as we move more and more towards the technology world, that option will become available. I think, people are talking about it now. There's some programs in some parts of the states that are using it more than others, so I really do see that happening more. I know, the home health agencies are certainly interested in that, so I see that as a coming feature, definitely.
Yeah, I think the regulators or the folks who develop the training standards need to answer that question. I think that I want to connect sort of the earlier question about compensation, and because it's related to the issue of the extent that the structures that we have in place, the policies, the licensing requirements, the hours requirements, right? How much alignment is there between the organizational strategies we have in order to grow this workforce with the incentives to grow the workforce, such as compensation, right, with what we're looking for? And they're not aligned, right? They're not. There's lots of opportunities there. At least in the behavioral health space, because of the innovation opportunity, we are seeing counties get pretty creative. So Jeff mentioned the peer certification bill in terms of the behavioral health workforce, and this is legislation that Governor Brown vetoed twice, that would create a payment mechanism under insurance, which I think 48 states already do, right? We're seeing Los Angeles County, for example, has already hired a director of practice for peers. They have a director of practice for psychiatry, for psychology, for their MFTs and their LCSWs, and now for peer providers. And so I think we're really at the very early days of recognizing the incentives and the opportunities to align things like, if you want us to work in an environment that is supported through telehealth, you need to recognize the training standards so that that fit is there. We're really at the early stages. We are thrilled that we're seeing counties starting to use their innovation dollars to figure this out. And we think that's the opportunity that California has, is to dig in and invest in those opportunities, because you're not going to see the traditional service delivery system meeting our needs at the traditional price point. And so if we want to better match what we can offer with what people need, we have to roll up our sleeves and figure this out.
Eric, you want to tackle that too?
I agree. And I'll just say that we could call ourselves the California Behavioral Health Network or Telepsych Network, because every single month, over 70%, some months it's over 80% of the live virtual consultations are behavioral health related. And we're not alone. When I talk to my colleagues in other states who have statewide or regional telehealth networks, the vast majority of the activity is behavioral health related. So,
Are most of those in an emergency department?
No. In clinic environments, or increasingly in the home for follow-up care. So, for instance, we have clinics, we have providers that specialize in substance use, anger management, episodic event kind of things. Those are generally more effective in going to where the patient is, because there's a lot of homelessness and that kind of thing. But the vast majority is the patient going to a conventional clinic and seeing a specialist via video conference from an exam room. And in a lot of cases, particularly in rural, where the communities are small and there's a stigma associated with going to see the psychiatrist or psychologist. They can go to the clinic. Nobody suspects that, there's nothing unusual about that. It removes some of the stigma of visiting the psychiatrist's office or the psychologist's office. It's a big deal also with veterans who don't want anybody to know that they may be struggling with certain issues. It's a different way of thinking, and any way we can use the technology to address that need, we're trying to do.
Just a quick add-on to what Eric said. So Dewan, who was mentioned as the mental health director here in Fresno County, she was on our subcommittee for the behavioral health workforce, and she said that 50% of Fresno County's visits are telehealth now. So that's an example, because of the need.
Can I say something regarding the question about education, too? I think one of the term that we need to get more used to using is the educational highway for people, where they can get on and off. If they start off as a CNA and want to go become an LVN, and then they want to work and then go back and become an RN, or a medical assistant that wants to go into, so we call it the educational highway, so that they can get on and off on these different levels and increase their ability to make more money.
So we have time for a couple more questions here and here, but go ahead.
My name is Joyce Eden, and I'm actually going to volunteer my site for the innovation money.
Which county are you from?
I'm actually from Fresno County,
Fresno
and I'm
County.
the Emergency Services Director at St. Agnes Medical Center. So we are very fortunate to be doing Lean Six Sigma work. I've also been blessed to be part of a research in the past, and we were taught to ask which patients are we most likely to harm next, and that's where we should be looking. So for the past about 14 months, I have actually been trying to find ways to be innovative and creative because these patients are not going to leave our emergency departments, and we have to deliver care differently, and we have to do that community effort. So we're also one of the sites doing telepsych as well. But so you validated some things that were starting to fold out in a picture for me, and on my list was actually to circle back in with Dewan or whomever would like to consider innovation. I'm also fortunate my CEO supports that, but we have to do something different. So the money is there, the will is there. How do we team up, and how do we do this differently that we can do things for people who just can't get it started for themselves? And it's not going to go away from our emergency department, so let's do it differently.
Fabulous. The reality is the money is held by the county, and so these are this is all the community planning process at the county level, and so it is a conversation with Dewan. We are actually seeing a number of counties that are increasingly reaching out to, so Orange County has something called a Be Well initiative. It involves all of their hospitals, all of their universities, their churches, their publicly elected officials, their largest employers, and they're stepping back and recognizing that too many people are coming through their ERs, too many people are being turned away by delays in care. There's some research that shows that the duration of untreated mental illness in the United States is about 56, 58 weeks, right? More than a year. It's 2 in the UK, right? Those delays lead to increased costs and delays in recovery, makes it much more difficult. People's lives begin to spiral in very negative ways. And so, we really are seeing communities come together better and recognizing how to leverage the respective resources that you have across the public sector and the private sector. So the long answer is it's really, really hard. The short answer is it starts with conversations with your behavioral health director.
So just real quick, Ms. Logman, did you have a comment? I have a question. Go ahead, and then we'll do this one last one over here.
Okay, thank you. Sonia, still, I think I'm stuck a little bit on sort of the notion of, sort of lower paying wages versus higher paying wages. And just from our lens, having seen what I understand to be a historical debate between, just as an example, respiratory care scope of practice versus vocational nursing scope of practice. And so I suppose maybe for one of you two, do you really feel like the industry sort of at this particular point in time is open to having some of those practice act conversations where, you know, somebody might have to give a little, you know, in order for sort of the greater good to prevail? And is any of that sort of coming through in your framework questions? And
yeah, I mean, scope of practice, as you know, are about the bloodiest things that happen in Sacramento. It's just really, really ugly because of, you know, people have trained their whole life and have a, you know, very strong feeling about their particular profession and their scope of practice. A lot of it has been about talking about people working at the top of their at the top of their license, not even like, you know, but there has been some of the pushing the bubble out a little bit, and that's where we've had there's been a certain amount of friction around that, because if it somehow gains a foothold in a commission or becomes part of a public document, you know, there's something, oh, well, the commission recommended it. So there is some stress right now within the commission members about trying to push the bubbles out a little bit. At the same time, I know from a funder perspective, we wanted it, maybe not radical surgery, but certainly something that's actually forward-looking, that looks at care coordination, and looks at care teams, and looks at trying, understanding we're not going to be able to provide every doctor, every specialist, you know, what can we do about, you know, other physician extenders and the work that the community colleges and the CSU do to provide larger numbers of care coordination team members. So I don't know what the legislature would do, but, you know, it's been a struggle even getting it to be a recommendation of the commission.
I would just echo what you said, and I think, but the way you articulated the question is, I think, a key one, and is the need is there, but the politics are also there, and also the financial incentives have to be there in order to make some of this change too. And I think we're not quite at the tipping. It doesn't seem like we're quite yet at the tipping point on all these, you know, of all those things magically coming together in order to make the kind of change. But maybe what the work that we're all doing here will, hopefully, it will get us in that direction. That's why we're looking at this as a 12-year implementation plan, not something that's going to happen tomorrow.
Last one.
Yes, great discussion. Thank you. My name is Valerie Fisher, and I'm with the Health Workforce Initiative with the California Community Colleges. And my question is for Mr. Brown. You know, the Central Valley is really large, and there's vast distances for individuals that have to travel from one place to another. And I'm wondering what's being done to increase the availability of broadband.
So that's the other hat I wear, is as an advocate for extending broadband deeper into rural California. We actually participate in a couple of federal programs that help pay for that. One is called the Rural Health Care Program that the FCC oversees as part of the Universal Service Fund. We're one of the largest applicants for that, and it can be used to subsidize up to 65% of the cost of deploying broadband to a rural or safety net clinic or hospital. In addition to that, the state of California has its own broadband subsidy program, which applies to those institutions. It's called the California Teleconnect Fund. It's administered through the Public Utilities Commission, and those two subsidies can be used together. So what we do is our organization does the filings on behalf of anchor institutions, clinics, and hospitals, because very often if you can find enough schools, libraries, clinics, and hospitals, you can attract a broadband provider that ordinarily wouldn't serve that area to serve that area. So that's one. The second thing that is occurring is we're seeing a new category, I don't know if they're new, but an emerging category of broadband provider, which are what I will call hybrid providers. So in the past, we've looked to the AT&Ts, the Verizons, the wireline folks to try to deploy fiber. That was the solution everybody was seeking. We still seek that, but we now see that there are other providers who use a combination of fiber and fixed wireless, so they're towers, and they can. We're finding that they can deliver gigabit speeds with high reliability and redundancy, and they can install those within 3 to 6 months, as opposed to taking years in some cases to build some rural locations. So we've been working with Scenic, which is our sister organization here, or brother organization here in California, that provides broadband to schools and libraries, to work with a select group of these new hybrid providers who've proven themselves, and we're forming up to see if we can go deeper into rural California. I'm happy to talk to you. In fact, this is a good time to be talking about this, because next July there will be a new tranche of funding made available from the FCC, and we're trying to line up as many locations as possible to utilize that funding between.
You heard it here first. You heard it here first. So I know we have to. I want to again thank the panelists for their participation in this outstanding workshop we had here. And I think they're gonna tell us how to eat, and then all of you can take turns trying to kill that fly that all of you have been trying to kill. You haven't seen it from here. I'm watching everybody kind of like, do I kill it here? Or do I swat it? Do I da da da? So go ahead. It's one fly that's bugging everybody.
Yeah. All right. It is time for our lunch service. I would like to excuse our keynote speakers to go first in line so they can get some lunch. Please feel free to go. Our lunch service will be through these doors. You'll enjoy, again, Harris Ranch's wonderful hospitality. I'm going to ask you to please get your food and come back, and when everybody's seated and ready to go, we'll get started with our two keynote speakers. We'll continue these amazing, rich conversations, too. So have a great lunch.